Welcome to Collab Conversations, the podcast where impactful discussions serve as catalysts for change. I'm your host, Sabrina Hanna, and this podcast is dedicated to advocacy and the individuals driving positive transformations in the Canadian healthcare landscape. In today's episode, I have Dr. Carol Cheung, who's a pathologist at University Health Network, an associate professor of laboratory medicine and pathobiology at the University of Toronto, and the deputy director of the Canadian Biomarker Quality Assurance, CBQA as the acronym, because I'm sure we'll say it again. So the CBQA program. And today we're going to talk everything pathology. But before we get started, Carol, maybe just give us a brief origin story.
Okay, my origin story it started way back actually, well before medical school. I was really interested in psychology, and it was mostly through reading stories and newspaper stories, whether they're or actually TV sort of specials about serial killers and such. And it was always interesting to me how people with different perspectives think, right? And clearly, sometimes the thinking is so is so different from what I experienced on a day-to-day basis, that I just found it fascinating to pore over these things. So I decided I wanted to go to medical school to become a psychiatrist. And of course, that didn't work out. But when I was in medical school, psychiatry, the interest for me was, again, understanding that perspective of what is going on and what is underlying the actions that certain people take because of whatever is going on in their minds. And what I found was that when I spent some time in pathology, I found that with respect to certainly something like oncology, pathology was where the answers were. Pathology was at the very root of where we found all the answers. And that I found really to resonate uh, very well with me at the time. And so I decided to go into pathology. And in some ways, it really is a little bit like the psychiatry of of disease, right? So it's about digging deeper and understanding and saying, what's the answer? What's going on right there? Especially in the field of cancer and in oncology, right? We're looking right at the tumor and saying, what's going on in the tumor itself, and to be able to help in that way.
Yeah, that's so interesting. That's like such a nice way to understand. Um, I
My
mean, also your
psychology.
your psychology and like how you ended up being a pathologist, but also thinking about like disease or pathology as the psychology of disease, because you're trying to understand. And if you relate it to true crime, like, the criminal behavioral people, they're thinking about like, why are they doing this? But then you're in your role, you're like, well, why is this happening? What is the interaction that's happening at the cellular level that is causing this cancer? So that's like a super interesting perspective.
I love the
And
way you put that. That is actually really good. But just so you know, I mean, not everyone has that view, right?
yeah, topic and talk about like the role of lab medicine in cancer.
hmm Well,
Or, so maybe explain to us a little bit before, like, I think we lab medicine and its role in cancer as a broader topic, but specifically for people who don't know what a pathologist does or how pathology impacts a cancer diagnosis, or we'll stick to cancer diagnosis. So maybe let's start there, and then we can talk about the larger or broader role of lab medicine.
so this is something where, I mean, we can do an entire series on this. But in general, especially in oncology, pathology is extremely important. I mean, pathologists are where that's where that's where the answers are
Mm,
in oncology, actually, because the fact is that the first part or one of the very first parts and most important parts of anyone who has any sort of a mass, any sort of a tumor, that might or might not be cancer, the first thing is to find out, well, is it, right?
mm,
And the second thing is to be able to determine, if it is, what kind is it? Because what kind of tumor it is or what type of tumor something is often dictates very much impacts on how that tumor is going to be treated. I mean, certainly there are other things like, of course, where it's located and is it surgically resectable? Like, can a surgeon actually take it out, and such? And those things we may not necessarily be able to impact a lot on, but the diagnosis itself is often key to determining what type of chemotherapies it may be amenable to, whether, well, we'll just keep it at that for now. And then as precision sort of medicine has progressed, and specifically precision oncology, if we're talking about cancer, then where we're talking about now precision diagnostics, which sits within essentially in pathology, that is an area where not only are we providing diagnostic information or an actual diagnosis, and I actually want to come back to that, the importance of the term diagnosis, actually. So if I forget, let's come back to that. But pathologists provide the information about the diagnosis. What is it? And we provide other information that helps with determining the next steps in management, which is whatever type it is, how close does it look? How closely does it resemble uh, what a non-cancerous, for example, cell type of that that particular tumor is based on? How close does it sort of resemble the original benign cells of that type? And because that gives us an idea of potentially how aggressive the tumor may be, how far has it spread? Sometimes when we're trying to when the surgeon is trying to take out all of the tumor, we can look and see whether has it potentially all been taken out, or is there some that may have been may have still been left behind. And has it, how far has it spread from the place that it started? Now we also provide, and then there's a lot of other parameters that we look at typically under the microscope. With precision diagnostics progressing, we now look at molecular level, so subcellular levels, parameters that will give us additional information, like whether certain types of mutations are present in a tumor, whether it expresses a certain type of protein. And those are things that we call them biomarkers. And a biomarker is just, it's what's the best way to say this? It's a thing, it's a substance. It's some sort of a biological substance that tells us something about an individual, whether it's, when we have this particular, when we find this substance, or when we find this molecular abnormality in either in a tumor or sometimes in non-tumorous tissue, then it gives us additional information. For example, in precision oncology, what this particular patient may respond to in terms of targeted therapies that are available currently.
Yeah.
So pathology is
Can you give like maybe a specific example, like of a biomarker, like an actual biomarker, and like maybe just explain it that way?
so let's go to lots of biomarkers. But you know what? One of the most common one, or one of the most, I suppose, most long-standing and the most famous ones is HER2 in breast cancer. So way back, I don't know my history well, I'd have to look that up. When a drug called Herceptin was created and became available. And this was many years ago. Sorry, I don't know how many. I'd have to look. Um, I think Dr. Dennis Slayman was I want to say 89. Now I really want to look this up to see. Should I do that or?
No, no, you keep
Oh,
talking and I'll look it up.
okay, okay, you look it up. So HER2 was really at the very beginning of I guess, targeted therapies the way we understand it today. And what the discovery was back then was that if patients had this particular abnormality that of their HER2 gene, then they would actually respond well to this specific drug. And so now that testing for that biomarker for HER2 positive breast cancers is how we just typically say it. When we look for that abnormality, that is now routinely done um, in patients with breast cancer, and that and its status actually, whether it's positive or negative, we'll say, um, for simplicity's sake, will help determine whether that patient is eligible for certain drugs that specifically target abnormalities in their HER2 gene. And so if you don't have that abnormality, or if we can't demonstrate it and report it as such, report that this biomarker is positive, then you would not be eligible for that particular drug. If we did find that abnormality, then you would say, oh, there's this option available. And of course, now there are more drugs than the original drug
Yeah.
that was available. More than just Herceptin now, but that is the concept of how biomarker status is used in precision oncology now. It's primarily to look at to be able to look for eligibility in disease treating options.
Yeah. And
Um,
so I've got an article pulled up here that's since its introduction in 1998, Herceptin has
okay,
saved nearly 3 million women's lives. And so this article was written in 2023, and it was the 25th anniversary of Herceptin.
that is amazing. I mean, that's where that was one of those in the beginning type
Yeah.
statements, right?
Yeah.
And things have just they've gotten progressively more advanced. We have many more biomarkers now, and the discovery of new biomarkers with associated treatments now are it's a very active space
Yeah.
in
Very.
precision oncology.
So there are a couple of things, but then I also want to go back to the cancer diagnosis because you told me to remind you. But you were
Yes, thank
talking
you.
about um, how now you're looking at the tumor molecularly. So maybe just like give us a brief evolution of like what you're looking at now versus what you were looking at 5 to 10 years ago.
So, okay.
Like, were
So
you also looking at it molecularly like 10 years ago, or is this since, I mean, obviously we just said that Herceptin's been around for 25 years and the BRCA gene was discovered 30 years ago. So, but precision medicine hasn't really been utilized in the way that it's being utilized now. So now you're looking at things. So I'll let you tell us like how has that changed?
So let me see if I can hit this one right. If not, just redirect me, right? So 5 to 10 years ago, um, we were looking. Let me just tell you actually first. So, radiologists look at images, right? They look at X-rays and they're looking at representations of us and our um, tumors and the patients inside the body, right? And it's not, they can't necessarily look directly at it because, well, it's most often inside the
Mhm.
body. Pathologists, we look at, for example, the tumor, we look at it directly after it's been taken out by, for example, a surgeon. So, and we sometimes look at a little part of it that they take out because depending on what it is, it may not be ideal to take out all of it, or maybe all of it can't be taken out, but we
Mhm.
still need to know what it is to direct management and treatment. So sometimes they take out a part of it, sometimes they take out all of it. And we look at the tumor itself and we look at it in little tiny 4 micron thick sections. So 4 microns thick. Just to give you a sense of what that is, um, a strand of human hair is like there's a range, right? Some hair is thicker, some is thinner, but I think it's around 70 to 100 microns. That's the thickness of a strand of hair. Pathologists look at tumors traditionally under the microscope as 4 micron thick sections. So, I mean, we don't just look at one 4 micron thick section. We look at a number of them, but that's what we're looking at.
Yeah. And so,
And
sorry, I'm going to direct you a little bit. So when you were looking at it, let's say 10 years ago, were you looking at it at a cellular level? Are you still looking at it at a cellular level? And like, is there a difference between cellular and molecular?
yes, so my PhD degree was actually it was done in the it was cellular and molecular biology. So there is technically a difference. A cell talks about things at the cellular level. Molecular talks about things, I suppose you could think about it at the subcellular level. So all the things that are inside a cell, all the molecules that are and structures that are inside a cell are subcellular. And the substances that and I suppose the molecules that make up all of the structures and the things that are inside our cells are what we're talking about mostly in terms of molecular testing.
Yes. So then do biomarkers fall under the molecular or the cellular?
I think typically they're like it typically is talking about molecules like DNA, like RNA, like proteins, and those are all things that are inside our cells. So I think when we talk about molecular biology, we're talking about um, we're talking about primarily those types of molecules, substances that are inside our cells. So DNA and RNA together as nucleic acids are a class of those molecules. Lipids, so fats, that is a composition of our cells. Proteins are certainly a composition of our cells. And I think what would be the other one? Maybe carbohydrates. So like the sugars in our cells. So those are kind of the way I think about the main substances that we're talking about when we're talking about molecular biology, and please don't ask me where that intersects with biochemistry.
No, I
You
definitely
know,
will not do that.
and
But
so
I will ask though, like how has evaluating those cancer cells in the pathology lab, has that evolved since the introduction of precision oncology?
yes. So what I described to you, how we traditionally, and I'm not talking 5 to 10 years ago, I'm talking decades ago, pathologists look at things in the 4 micron
Yeah.
uh, at the 4 micron level. We still do that today. That is the underlying basis of, of what starts a diagnosis in for a tumor. So we still look at that, but the additional tools that we have to look at the specifics of what we may be seeing in those 4 micron sections has become more more sophisticated and more available. It's allowed us to do additional testing that gives us more information that will be able to help with patient care. So, for example, um, we'll just say for HER2. For HER2, currently, I mean, for years, we were looking at HER2 as a protein um, test, essentially. So on the 4 micron sections that we look at, we would look at for HER2 abnormalities based on the HER2 protein. And because what we were specifically looking for was overexpression, that there was more HER2 essentially being expressed. I'm trying not to go into too many of the specific details, right? But tell me if you want to know them. But we are looking for more HER2. So usually the way our HER2 testing works is that on one of those sections, if the and on one of those sections that has the breast cancer cells on it, if there is no HER2 abnormality, that would make someone eligible for Herceptin, then we don't see any signal when we're looking for when we put an antibody against HER2 onto those cancer cells that we have in our hands. When that abnormality is present and we put an antibody is something that it's a reagent that helps detect protein abnormalities. When we put that onto the tumor cells, we see a certain signal come back to us, and we call it positive based on certain certain criteria that we have to call something positive. And when we see that, we can say that, okay, this one does have the HER2 abnormality that would um, make this patient eligible for Herceptin. So we report it as such. And for many years, that was what was mostly available. As time has gone on, we have more different antibodies that we use to test for different abnormalities that can guide treatment. We have more tests now that, for example, look directly at the DNA sequence. So proteins are they're the workhorses of any cell, and they're the ones that typically do most of the work in the cell, whatever that work is, whether it's to divide into two new cells, whether it's to just like for example in a liver cell, if one of the things that needs to be done in that cell is to make a substance, whatever it is, and secrete it into the body so that we can use it for other things. Those are the proteins in the cells that are doing that, um, and then they carry on, right? The
Mhm.
proteins are actually, they get made by the cell itself based on what the DNA of that cell is telling it to do. So a lot of times the proteins could be it's a manifestation of what's happening at the DNA level. So DNA is it's our recipe book. We all have one that's individual to us. It's the recipe of how to make you, right? And how to make me. And the only people that have the same DNA is your identical twin. And if you don't have one, then you're completely unique. Um, and so as time has gone on, we have additional techniques that don't only allow us to look at the cells um, sort of under the microscope I guess at more of a cellular level. We had antibodies that can help us look at the proteins. And specifically now, we have more and more ability to look directly at the DNA itself, because sometimes DNA abnormalities don't translate into protein abnormalities.
Mhm.
And but sometimes you can only look for certain abnormalities through the protein type of testing itself. So as time has gone on, we have more and more ability to look at more and more different biomarkers using actually new technologies that can look at different substances in and different alterations within those substances
Yeah.
in a practical way.
So I want to ask about these new technologies, but I'm going to let you make your point about the cancer diagnosis.
But
Yeah.
basically, yeah, we look at we as we have more techniques and we can look at more things, it like we can look at more different substances and abnormalities. But there are, as science progresses, we are also able to use those techniques to look for more abnormalities themselves, not more different kinds of abnormalities, but within those kinds of abnormalities, just more abnormalities on their own, right?
Yeah.
Um,
Yeah. So it's like, I guess if we think like of an analogy, which
okay.
actually it's really not like an analogy, but if we think about lung cancer, maybe 10 years ago we were classifying lung cancer as lung cancer, but now we're thinking about lung cancer as a ROS1 or ALK or I mean, EGFR. So, like, we're actually classifying it into different types of lung cancer. And then within those lung cancers, those different types of lung cancers. And then I guess we could also say there was the smoking lung cancers and then the non-smoking lung cancers. And then we can just keep breaking them down into different types of lung cancers.
Yeah, that's a good way to think about it. I think it's really just how much more information can we return?
Yeah.
And that information is it's growing. So there's more and more information, which when they're linked to treatment options, means that there's more and more um,
Or
options for
yeah,
for
different ways to treat.
oncology patients.
Yeah.
And that's where pathology really brings its value, resting always in the diagnosis because that drives everything at its core, and then being able to sort of contribute increasing amounts of biomarker information that can help with determining treatment eligibility. So back to the diagnosis, right? I
Yeah.
wanted to say that, and it was where what I found was interesting was that differentiation between lab medicine and lab services. They're very closely tied in together because, as you know, in the practice of medicine, it's never a solo sport, right? It's all, and the best medicine is through collaboration, of course, because the more information you have, the more input you have, the more perspectives you have, actually, the better. And I mean, as in our conversations, we've certainly come across the fact that at a bigger systems level, it becomes the more perspectives you have, we can see how that's actually very beneficial to the system as a whole. But if we go back down to say the tumor, right? Um, Aspect of it, I was thinking, how do you tell the difference between a lab result and a pathologist's report? Because I think everyone thinks about them as, oh, it's the lab report. Actually, a pathologist's report is something a little bit different. It rolls in a lot of lab results, but it's a report because a pathologist's report, it's a diagnostic report. So what you will always see is a diagnosis. There is always a diagnosis field in it because diagnosis it's one of those at least in Ontario, it's one of those things that falls under the Medicine Act. It's the ability to provide actually a diagnosis, or specifically they say to communicate one, along with other things like being able to perform certain procedures um, under the skin, right? And to be able to prescribe drugs and order investigations and things like that. It's the ability to render a diagnosis which is actually different than a lab result.
Yeah.
For a lab result, there is no diagnosis. Like say you get a lab report back, result back, where it says, I don't know, your hemoglobin level. Your
I
hemoglobin
was just about
level.
to say
Oh,
that.
interesting. Um, your hemoglobin level is this. There's no diagnosis attached to that, right? Whereas if you read actually a pathologist report that was issued by a pathologist, it will always have a diagnosis field where there's going to be a diagnosis. There's lots of other things that where we will also report out a certain lab investigation, what do you call it, results, right? So a pathology report that's issued by a pathologist actually is not, it's not a lab result.
Yeah.
It's an
That's
actual,
actually really interesting, and I'm glad that you brought it up. And so, like, now I have a lot more questions. I'm
okay,
I'm gonna try to like ask as many questions as I can.
okay.
So, now you're saying that a pathology report always has a diagnosis. So how does the medical oncologist and a pathologist? So, I mean, I always just assumed that the oncologist would do the diagnosis. but I guess, like he can't, or he or she can't do that diagnosis without that pathology report. So like maybe talk to me a little bit about the relationship between the pathologist and the medical oncologist, or I guess even, in breast cancer, it could just be a surgical oncologist. So talk to me a little bit about that relationship.
Well, that's an interesting question. I mean, we're all on the, we're all on the team, of course, and I think,
Well, so then maybe let me ask you this.
yeah.
How do you work as a team in making that diagnosis for someone who has cancer?
So here's the interesting thing because all physicians have the ability to diagnose, right? And or have the like that's one of the central um not tenets, but well, it's in the Medicine Act. That's something you require a license to, like having a a license to practice medicine means that you can perform these activities, right? And such. And diagnosis is certainly one of them. So if we go out of cancer for a minute, right? Let's just say you have, I don't know, talk about diabetes, right? In order to make a diagnosis of you having diabetes, whether it's type 1, type 2, whatever the case may be, that diagnosis would be made by the physician who is, for example, taking in all of the results. And so, for example, and should I be doing this? Because how much do I really know about diabetes? But we'll just work with that for right now. As a physician, they'll take a history from you. They'll say, oh, um, blah, blah, do you have these types of symptoms? Do you have, they'll do a physical exam on you and see certain things about you. They'll do blood tests on you, let's just say, for example, and they will get those lab results back. None of them will have a diagnosis on it, right?
Mhm.
Because for example, they'll draw your blood and test for certain substances, we'll say, and put it together with certain symptoms that you may have, certain things that maybe run in your family's history, and something like that. That physician, whether it's maybe your general practitioner, right, your family physician, they will at some point come to a conclusion based on all of that information, and they will actually issue something called a diagnosis. Whether they document that in their chart, or they may refer you to a specialist physician who will then issue a report back to your family physician to say, and the diagnosis is, uh, you know, be it diabetes or something like that. In cancer, it's a little bit different because, and there, for example, the diagnosis itself on that report is actually for certain tumors, it is made by the pathologist. And in many ways, while everyone works at a team to come to that, because history can be very important in terms of the diagnosis that we make. So it's important that we have access to the clinical history, the chart, and stuff, and such. Where in some instances it does help provide information to. For us to come up with a particular diagnosis, even as we're examining the tumor itself, right? Um, the medical context certainly is important, and those are things that are generated and collected by our direct patient interacting physician colleagues. And
Mhm.
so we take all of that information, and ultimately for cancer, a lot of the times we are the ones that issue the actual diagnosis in oncology. Um, Certainly we don't do it by ourselves, because if there was no opportunity to examine that tissue because nobody was able to take a sample of it, right? The diagnosis wouldn't come, and it certainly wouldn't come from us.
Yeah.
Um, there are certainly, our radiologist colleagues, contribute to that. And such, certainly our surgery colleagues, actually a lot of our colleagues, do that. But I guess what I'm trying to say is that I think for cancer, ultimately it is the pathologist that is issuing that diagnosis. We can't always make a diagnosis very definitive, sometimes, right? Oftentimes we do, but sometimes a tumor may be so poorly differentiated that we don't know with all of the testing, all of the techniques, whether it's through microscopy, um, through the different lab techniques that look at proteins and DNA, we still won't be able to come to something definitive. And in those cases, our for example, our oncologist colleagues, they may say, well, I'm going to treat it as this. They may not have a definitive diagnosis in that case, but they will be the ones to determine the treatment plan going forward. And sometimes, even when we do issue a definitive diagnosis, they may say, well, based on, or they definitely do say, based on the characteristics of this particular patient, even when it's given the specific diagnosis, I would have to take this into account to decide what type of therapy maybe that patient can tolerate or, which direction to go in. So I have to say that, yes, in oncology, it uh, really one of the greatly important roles of a pathologist is to render a diagnosis as definitively as we can and to provide sort of uh, additional parameters and information that will help with treatment, most especially including biomarker
Yeah.
statuses.
So then talk to me a little bit about the difference between diagnosing a cancer based on the molecular profile of the tumor versus the tumor site.
What do you mean by the tumor site?
So like diagnosing a cancer like an EGFR or an NTRK versus diagnosing like a lung cancer or a prostate cancer or a breast cancer.
So that usually almost always comes first. First, we have to know what it is. Like we always start with what is it? So we'll
Mhm.
always say, we'll always type the cancer. What type of cancer is it first? Then
And
things
so
like,
for you, what like when you say what type of cancer is it, do you mean like where it's located or do you mean a molecular profile?
we mean, well, where it's, no, we mean um, I guess what we call the histologic origin of it. Like, is it a cancer of that, of breast, epithelial
Tissue?
cells,
Yeah.
or yes, of breast tissue? Is it a cancer of liver cells? Is it a cancer of, say, prostate cells? And where it is isn't always helpful because cancers spread and they show up in unexpected locations. Most often, if they have not spread to other parts of the body, where you find it is typically where it originated. So, a
But
cancer.
then how is that, sorry, I just, how is where it originated? Like how, I'm just thinking about like biomarkers now and how, you're using biomarkers to make treatment decisions. You're the pathologist and the medical oncologist or whatever type of oncologist it is, how they're using those biomarkers to make those treatment decisions versus where it's the histological history, I think you said.
So, um, the type of tumor that it is often is a
So
big
where it's
drive.
located,
Where it's presumed
origin.
origins located, because there are some spots in our body that are really prone to have other cancers come to it.
Hmm.
It's a very welcoming ground, it seems. And like, for
Yeah.
example, the
But
liver.
but also some biomarkers that are more prevalent depending on where it's located as well, right? Like if I
Yes.
think like just off the top of my head, if I think BRAF, like we know like in melanoma or in colorectal, but we don't necessarily think of BRAF in I don't know, like kidney cancer. We won't, or maybe we do.
Hmm.
But there are like certain biomarkers have been associated to certain cancers. And when I say
Yes.
certain cancers, like where they're located.
So biomarkers to help determine eligibility for therapy. which I guess we call those actionable biomarkers, right? Because we can find some sort of abnormality that is actually actionable. Those are those are usually we find them and we accept them and we're allowed to use them based on evidence that's been generated. And and that leads back to the sort of regulatory aspects of drugs and approvals and things like that. And drugs are typically approved for based on specific evidence that are generated from clinical trials, uh, typically. And in a clinical trials are very specific and clear as to what patient population is being evaluated, what tumor is being evaluated based on based on mostly histological origins typing as we know it for now.
For
A
now.
lot of
Yeah.
them are building biomarkers into that, but they really are still very tumor type specific in a specific patient population, plus or minus um, some biomarker status, which may have been something that was put in at the beginning of the trial, or may have been something that gets looked at after the trial
Hmm.
results come out. And in those trials, the participants are often, for example, there's a comparison of a treatment and essentially not that treatment, whether it's a different treatment or the current treatment and a new treatment.
Hmm.
And they look for the well, I mean that's a clinical trials sort of discussion, but where that then translates into practice is that when that therapy becomes available, it'll go through that evidence gets evaluated by the regulatory bodies. So, for example, the US FDA is the most
No.
it's the most known. And of course, for us here in Canada, it's Health Canada. And when a drug is approved, it's always approved for something very specific that they call the label. And this is what, Health Canada has said is, this is what the approval is for. It's allowed to be marketed and sold for Canadian patients um, under these conditions, right? And they are that, whatever it may be, that it's this type of tumor, maybe in potentially in a population. I'm trying to think of some approvals I've seen, and sometimes they now include a particular biomarker status. And so when we're looking at things, we still always look at first to what is it? Because
Mhm.
not every tumor has necessarily actionable
Biomarkers. Yeah.
biomarkers. And even if we just sort of, without looking at them to see this or that, we just sort of put them in and did a big molecular profile on them, like a really comprehensive molecular profile, maybe we won't find anything, right?
Mhm.
And then, but there's a lot of treatment options that may not be specifically what we associate with precision oncology, targeted therapies and such that the tumor type, accurate tumor typing actually drives that type of treatment decision because it's just because it's not targeted, it doesn't mean that that patient wouldn't get any treatment at all, right? They would get the treatment that
Yeah.
is best known to have some impact on that particular disease.
Yeah. And so you talked about the actionable mutations, but do you want to define what the actionable mutations are and then also define what the non-actionable mutations are or biomarkers or,
So I think uh so actionable when we're talking about mutations, of course, we're talking about DNA, and then all of the techniques that are relevant to specifically being able to give us information about DNA from the tumor, for example. And so when we say something is actionable, it means that, well, when you find this particular abnormality, there's potentially something you can do about it. There is a drug that you can give that specifically is designed to target that particular abnormality. So if you can find it, then it's considered actionable. And of course, the best type of biomarker to be able to identify are those that have some ability to impact treatment and to open up options and such for patients. Non-actionable biomarkers, obviously they're of less interest in the immediate here and now, right? But because and that comes about from the way the technology has evolved. Because now we can see so much more. Like like our eyes are just now completely open to more and more things, and we can see things that currently they may not have anything that is associated with something that is actionable, but because of the technology, we're able to get all of that information out and then sort it into, okay, well, this isn't currently actionable, this is not actionable currently, but the information is still out. So it would be helpful in a case where things became actionable in the future. In that case, you have that particular information already available if it was relevant to the tumor and the time at which your tumor was actually tested. And sometimes that's not always the case. Um, so yes, so it's the actionable mutations for any particular patient that I think is most important, and
Yeah.
certainly what
And
we
so
focus on.
earlier you talked about how, new technologies are allowing you to do more. And now like you sort of said it now about how you're able to see more, and whether you can use that information to treat or not treat is obviously like different. But now can you talk to us a little bit about like how you're seeing more?
Oh, yes. Oh, that's NGS testing. Yeah. So NGS testing is it's one of I mean, there's always new technologies coming down the pipeline, but we hear a lot about NGS testing now, right? And so NGS is is a is a is a technique that is used to look to help identify abnormalities in DNA, and that in itself is a huge it's a huge area, not only from the technology perspective, but just imagine if you could yeah, you seen those there was this movie a long time ago where someone essentially, I think it was a Keanu Reeves movie, right? They downloaded all of this information into his brain or something like that. Do you remember? Have you heard of it? Like it was like, what's it? Johnny Mnemonic, maybe. Is
Oh,
that
maybe. That sounds right.
something like that? Where all of this, actually, speaking of that particular actor, which if you think of the Matrix, right? Where he comes out, he says, "Oh, I know kung fu," all of a sudden, right? Because that was put into his brain, right? Like it. So, anyways, with NGS, there's a you can get all that information out, right? But to make sense of it and such is actually a lot of work. So the in terms of the process of NGS, there are multiple steps. One of them is, of course, to get at the DNA. Like you have to get the DNA out so that it can be tested on the instruments, right? And then you actually have to be able to identify the sequences in the DNA. And our DNA actually it only consists of essentially four, um, like if you think about a phone number, right? A phone number is what? Uh, it's 10
10
digits, right?
digits.
Including the area code. I don't know if it's the country code as well, then it's 11, right? I don't know. Anyways, I shouldn't say that.
Yeah, no. In
Maybe
Europe it
more.
would be 12, yeah.
Oh, so so if we think of it like a phone number, it's 10 digits in Canada. But oh, maybe that's not the best way to think about it. But and it can only really be composed of like, the digits, like your options for the first part of your phone number is really 0 to 9, right? Those are your options. And then all of our phone numbers are some combination of that, and there are 10 of those in a row. Uh, and that gives us lots and lots of phone numbers. For DNA, there's really, instead of 0 to 9, it's really only 0 to 3. So there's only like four, four options that you can have to string together a big long molecule of DNA of which we are all unique, right? And those things, instead of 0, 1, 2, 3 or 1, 2, 3, 4, it's A, T, C, and G, and they stand for something called they're nitrogenous bases, which are, which is represented by the letters A, T, C, and G. If you want to know what those mean, we can talk about that too, or what they stand for.
Well, no, I just want to say, because and for anybody who's done a 23andMe report, and if
Okay.
they've ever taken the time to look at their raw data, and they know that, like, so if they're looking at whatever gene expression that they have, they will see like the gene they're looking at, and then like the combination, like you said, of the two different letters. So it's like a CC or a TT or a TC, and then like on 23andMe, it'll tell you like and I like can't think of a specific example, but if you're a CC, then this means this, and if you're a CT, then this means this, and if you're an AC, it means this, based on like for this gene. So, for example, I have the fat gene.
What?
So I have the fat gene. I don't remember what the gene number is, but I have like those two letters together that predispose me to being overweight. So thank
Oh,
you for clarifying that for me. Anyway,
oh,
carry on.
it's composed of those four letters, and for me, we'll say position 1 of the DNA molecule that forms my chromosome 1, because 23andMe, like we have more than one chromosome, and each of those chromosomes represents a single DNA molecule that has been folded up and rearranged and greatly condensed into something that's very small. But it contains all of the information that we need to make us us. And so, if you start at chromosome 1, that DNA molecule position 1, like, then you start filling it in. Okay, A, T, C, 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 G, T, A, T, G, and such. And with those four bases, we have a massive number of unique um, people in the world, right? And so I was just trying to think of what is the population of the world.
I think it's like 8 billion.
Is it? Now I want to find out.
I'm going to look it up while you keep talking.
So because with that, with those four bases, we have the ability to come up with X billion unique individuals. And so as technology has progressed, we now have the ability to find out exactly what order those DNA bases, or your DNA sequence, is in for every particular individual. And as we said, did you find out how many?
Yeah, 7.95 billion.
Billion. So nearly 8 billion people all have
Their own
unique
unique genetic code.
DNA
Yeah.
sequences, their whole code. There will be areas of our DNA that are very similar to each other. And actually, that may well be identical. And this is another sort of really fascinating thing, I think. I mean, what was it? And I should remember these things when I see them. I mean, we're always taught about homology, interspecies homology. I mean, as humans, we're all in the same species. But if you think about an actual different species that are non-human, there is a lot of our DNA where we share the same DNA sequences as
Like an insect.
yes, and it's actually very fascinating just how much
Yeah.
DNA needs to be
I,
different as our technology, because there's other techniques and methodologies that allow us to look at DNA, right? So, like for example, PCR is one of those things. PCR allows us to look at DNA, or and sometimes RNA. But it allows us to look for abnormalities in DNA. But you could look in a very specific area, and you can imagine just how much DNA we actually have. PCR allowed us, for example, to look at something, a very small piece of our DNA, looking for a very small change. Like maybe instead of, if in that area we have well, we'll just say ATCG. Instead of that, the T has now become an A. It allows us to look at that sort of level of specificity potentially. Um,
so we are 60% identical to the fruit fly.
Oh yes, so yes, the fruit fly. Yes, fond memories of the fruit fly. There did some work on my
And we're
supervisor's lab.
so there's an article on Pfizer's website, Pfizer.com, and it said Here it says nearly 75% of genes that cause disease in humans are also found in fruit flies, making them good models for the study of human disease.
Yeah, no,
Interesting.
I did some work in with fruit flies during my PhD, so that was rather
Really?
fun. Well, my supervisor was very, he's like a super scientist who will utilize any technique possible to
All
and
right, that
available
sounds interesting.
to make advances in science. So
I think we're going to have more conversations because actually that was fun looking up how identical we are to fruit flies. That discussion was fun. But there are other questions that I want to
okay,
ask.
wait, let's go back to the techniques thing. You were
Yes,
saying how, right? So I should at least answer that question, right?
yes, please answer
So
that question.
as we have more and more, say if we're talking about looking at DNA, as we get more um, and as there's more and more development in techniques that can look at DNA and more importantly, look at more and more DNA at the same time, because there's so much of it, we are able then from a technology perspective to pull out a lot more information about, say, a tumor, the DNA that's in the tumor. We can pull out a lot of information on that. But what specifically in terms of NGS, now that you've pulled out all of that information, what are you going to do with it? Like imagine having like, in the Matrix or whatever, having a lot of information downloaded in your brain. You're almost like I don't even know how to make sense of it. And that's where a lot of I think the field of bioinformatics to organize that information, to make sense of it, to help identify all of the noise that's coming through is extremely important. So that's where the bioinformatics, for example, aspect of looking at NGS data and being able to make sense of it. Initially, it's of course focused on looking at things that abnormalities that we know are associated with or that are actionable and that we know are associated with some sort of a therapy, right? The fact is that the vast amounts of information that has been left, depending on the type of NGS, um, testing that you're running, the vast amount of information is it's just left behind. It's still there. And if you go and troll through it and, search through it and dig through it, you'll find lots of additional information. We haven't yet caught up to being able to, I think, make sense of all of that, partially because I think science also hasn't caught up with the discoveries of what the currently I don't want to say it's not forgotten and it's not left behind. It's just unexamined, right? DNA information that we may have from tumors. We don't know what disease parameters it may be associated with, and we don't know what treatments and drugs it may be associated to because scientifically and medically that hasn't been either discovered or it hasn't had a clinical trial that has generated that evidence to allow us to know that it's meaningful information to actually pull out. So I think that's where I think when you were asking how has the technology sort of evolved into being able to generate a lot of information that isn't currently identified to be actionable, how has that or how might that impact the future of precision diagnostics? I think that's where it kind of sits. It's not, it's all there and it needs to be examined and analyzed. And that in itself is a lot of, there's a lot of resources and work that needs to go into there. And if a tumor has progressed somehow, and because we know that tumors progress through potentially accumulating additional damage, if it's like that can be done through additional DNA changes. So if you have all that information for a previous tumor, does the sort of progressed version of that tumor, is that same information from the original as meaningful as, or do you need to do that testing all over again? And sometimes I think you do, and sometimes you don't. And that is something that as science progresses, it'll be that'll sort of get itself sorted out.
Yeah. And so when you talk about precision diagnostics, so we've just talked about the next generation sequencing. I had a little brain fart there. So you've been talking about the next generation sequencing, the NGS, but within precision oncology, precision diagnostics, there's the NGS, but there's the comprehensive genomic profiling, but there's also companion diagnostics. So um maybe briefly talk to us about like what is what and when would what be used.
So I think so I think NGS as is definitely a technique, right? And comprehensive a comprehensive genomic profile is can be generated using NGS as a technique.
So NGS is a technique and CGP is the result.
Yes, it could be, and but I know people also use the phrase comprehensive genomic profiling,
Okay. As a
and I think
technique.
and that is typically, unless I'm wrong, and we'll have to look into that. Comprehensive genomic profiling is, I think it's sort of like almost like a short way of saying we'll be using NGS to generate a report where I can look at a large number of potentially actionable DNA genomic abnormalities to see if I can help um, with finding a treatment that could be effective against this particular tumor. I
Okay.
think if you deconstruct it, that's how it's being used.
I
I'm not
think I
sure.
think this is a conversation we're gonna continue to have because I'm sure that a lot of people are, or maybe it's just me. I need more clarity on the topic. So let's go to the companion diagnostic and then I want to talk to you about cutting edge.
Okay. So when someone is saying that you're gonna if that comes up that you're gonna get companion diagnostic testing, it means that again, it revolves around the targeted therapy concept. Actually, all of these actually you can bring that back to the common denominator of targeted therapies because that's what everyone is sort of looking for, right? They're looking for something that will target a particular abnormality.
Mhm.
And in companion diagnostic testing, like there's already a pair that is known. So abnormality A of or which can be denoted as say biomarker A is associated with in this particular disease population with potential response to this particular drug. That is sort of a very companion diagnostic uh, um, companion diagnostic framework.
Mhm.
So in terms of testing, I always think about companion diagnostics as being the three Ds, right? There's the drug, the diagnostic a testing or test itself, as well as the disease, essentially, which is typically the tumor type, right? And those three things get tied together as almost a unit. It's not like a Tylenol where you just take it for whatever in general. Companion diagnostics implies that there is that specific tie between a drug, a particular disease, and a particular diagnostic assay. So
Okay, and
companion
that's the
di
difference between the NGS and the companion diagnostic. The companion diagnostic is associated, there's a companion drug that goes with the test and a
there is,
companion biomarker that goes.
yes, which you can also use NGS to identify.
Yeah.
So
Well,
they're overlapping. Yeah,
yeah, they're overlapping, which
they're
I think
overlapping.
I feel like I need more clarity. I don't want to say other people are going to need more clarity, but I feel like I'm going to need more clarity. And so maybe this will be like an ongoing discussion that we can have, and especially in terms of Precision Medicine Awareness Month, where we can dive a little deeper into those specific topics. But did you want to add something to that?
Um, No, I only wanted to say that that's why our next project after the one we've been currently working on is actually of interest because I think because communication is actually so important, right? And when you're not really talking about the same thing, or you think you are, which is even worse, right? If you think you are and you're really not, there's there's lots of opportunity for um uh there's
Gaps.
lots of opportunities to do better then, right?
Yeah,
So,
yeah, yeah.
and it would be such a shame. And I think terminology is probably one of the most important things, being on the same page about things, right?
All right.
Yeah.
So do you want to talk to us a little bit about cutting edge?
Yeah, sure. Thank you. That would be great. So, CBQA's Cutting Edge, it's a webinar series that it was launched by the Canadian Biomarker Quality Assurance Program, or CBQA, that explores issues that either directly or indirectly impact biomarker testing in precision diagnostics, and specifically um, through the lens of the Canadian precision oncology landscape. It's a big country, and CBQA's Cutting Edge series represents a way to bring the Canadian biomarker testing community closer together in terms of us being able to share experiences, practices, challenges, and the goal is to improve, of course, first safety, quality, efficiency, and of course, as in our work together, access. Uh, and what I find is that, of course, the target audience is the sort of Canadian biomarker sort of testing community. And what I found is that as the series goes on, and as we're talking about more and more things that may not be directly, but also like sort of adjacent to biomarker testing, that I think that audience is actually expanding, right? And that is, I think, well illustrated by the episode that you will be joining me on Cutting Edge for on October 31st.
Yeah, with Dr.
Where
Shakil Kassam. Not just
Yes.
me, Dr. Shakil Kassam as
Oh,
well.
sorry. Yes, absolutely. Both of you. He is an oncologist, and you are the head of a patient advocacy think tank, right? And I'm a pathologist, and it seems like certainly that particular trio together on the same webinar. Actually, I'm not actually on the webinar. I'm just hosting and moderating. The two of you are actually going to be on the webinar, but the fact that you're on coming onto a webinar series that traditionally doesn't see that type of, I guess, interaction and such, I think is actually very interesting and very important. And I think that it's just an expansion of our understanding of the things that actually impact biomarker testing and medicine in general. I mean, when we're practicing, it's very easy to say, okay, this is the next case or the next patient in front of me. I have to analyze this and essentially issue a diagnosis, right? In the report along with all this information. But and then you're thinking, oh, there are just so many challenges. We don't have sufficient this. We don't have enough time. We don't have enough resources. And you're thinking about that all to yourself. But then as we've been talking and as I've been sort of doing the cutting edge, there are so many things that feed into that and impact the work that I'm doing that isn't directly work that I am doing, that I actually find it very interesting and rewarding and hopefully helpful. That cutting edge is able to take that expanded view of how precision diagnostics fits within the precision oncology framework, also incorporating sort of aspects that are outside of direct medical practice.
And so on the 31st, Dr. Shakil Kassam and myself will be joining you on Cutting Edge to talk about, and so the episode is called Precision Diagnostics and Oncology, Who Pays? And we've been looking at the funding pathways for the companion diagnostics, and it's not as well identified or talked about, or it's not in the literature the same way the oncology drugs are. And so you and I have been looking into this, and it's been an interesting process. And so, when I think about, who pays, for me at this point, the patients are paying because because there isn't that framework that exists to make sure that the drug and the test are being funded and accessible for patients. And so I think we're not, I think, I know we're going to be discussing this, and Shaq is going to bring a really interesting perspective, because as an oncologist, he's been spearheading that testing in his hospital, which is a community-based hospital. It's not an academic center. And so it's going to be an interesting conversation. And I think he's bringing a really great lens to that conversation, because as an oncologist who previously didn't have access to that testing, and he was telling us in a call that we had with him how he knew, like, he had a patient in front of him and he knew that he needed to be tested for a biomarker because he would be a candidate for a specific drug, but he couldn't get that testing for that patient done. And he watched that patient die, and that is how he has started this testing program within his hospital. So I'll stop there. And if you want to learn more, then you can join us on the 31st. So we'll be talking more about that, but I will include the link. And so thank you, Carol. I think this was like, I been talking to you so often, have learned more today as well. And I continue to learn every time I speak to you, but I love how you educate me, and like the words that you use to educate me on what is happening in pathology, and how that helps me do my work. So I appreciate you, and I appreciate this discussion. And I think that what I will do, which I don't normally do, but if anybody has any questions related to what we've talked about, because I know I've got questions on the NGS and the CGP and all that stuff. So I'm gonna I'll ask you to email me or to leave a comment, whether it's on Spotify or podcasts or YouTube. Leave a comment, send me an email, and I think that Carol and I could definitely have more discussions, and if other people want to join into the discussion too, that would be fun. So on that, thank you, Carol, so much. And
No, I want to thank you too. Just I know you want to wrap up, but but no, I want to thank you too, because I learn a lot from you also. It's not one way, that's for sure. And I find that sometimes I really like different perspectives, and I find yours to be actually extremely interesting and illuminating, and also very educational for me. So thank you for inviting me to be your chatting partner many times. Thank you for working with me on things like Cutting Edge. So yes, just thank you.
thank you. And I'm going to stop there.